CDU Works in Progress is a collaborative research activity with our Vice President for Research and Health Affairs, Access, and also the Urban Health Institute. CDU Works in Progress is a quarterly research series designed to serve as a forum for CDU researchers to share proposed, new, ongoing, and completed research. Our objectives are to discuss research ideas, study design and implementation, results and dissemination, facilitate research collaboration, and also to increase awareness of research areas at CDU. At this moment, I'd like to introduce both of our featured speakers for today. Firstly, I'd like to introduce Dr. Angela Venegas-Murillo. Dr. Venegas-Murillo is an assistant professor and general pediatrician in the Department of Pediatrics and Urban Health Institute at Charles R. Drew University of Medicine and Science. Dr. Venegas-Murillo graduated from Stanford School of Medicine in 2013, and she completed her residency training in the social pediatrics program at the Children's Hospital at Montefiore in 2016. Dr. Venegas-Murillo is also a past UCLA National Clinician Scholar, and her current research is with LA's Best, and it focuses on the resilience of building in trauma-afflicted communities through implementation of social and emotional learning programming in elementary after-school setting. Next, I'd like to introduce Dr. Dilara Üsküp. Dr. Dilara Üsküp is an investigator in the Department of Family Medicine at the University of California, Los Angeles, and also an assistant professor in internal medicine at Charles R. Drew University of Medicine and Science. Dr. Üsküp is a joint doctoral graduate of the University of Chicago's Department of Political Science and the Divinity School. She was the first in the university's history to be both awarded a PhD in political science and a PhD in theology from the Divinity School. She completed her NIH/NIMH training at the UCLA Center for HIV Identification, Prevention, and Treatment Services. Her current research investigates the ways religious and political institutions, attitudes, and ideology interact and shape health behavior to inform public policy. Please join me in welcoming both Dr. Venegas-Murillo and Dr. Dilara Üsküp. We'll start with Dr. Venegas-Murillo's presentation.
Thank you, Caroline, and thank you, UHI and Access for inviting me to present today my work in progress. So I'll be sharing my screen. Okay, so in Caroline's introduction, she talked a little bit about the work that I was doing in my early years as a researcher with LA's Best and trauma-informed work that I've been doing in an after-school setting, but I've now expanded my frontiers to try to extend that work into the primary care setting. So the work that I'm going to be talking about today is on integrating basically trauma-informed childhood obesity care for low-income minorities in the primary care setting. And so just financial disclosures, I have no financial interests or relationships to disclose. I do want to start with some background as far as the public health crisis that we're currently living in, above and beyond what's going on with the COVID-19 pandemic. In the last 60 years, motor vehicle accidents were the leading cause of death in children. And just recently, this year, firearms have now become the leading cause of death among children. Specifically, firearm violence has increased during the COVID-19 pandemic. And we've seen that firearm violence, unfortunately, is disproportionately affecting low-income communities of color, and specifically communities like South LA. I was just invited to speak in April of this year at the Childhood Violence Summit, Exposure to Violence Summit. And we had speakers from LAPD, from the city attorney's office, who were talking about what they're seeing now in the streets of South LA, that they are seeing an increase, unfortunately, in firearm violence and childhood exposure to violence. In addition, adverse childhood experiences, otherwise known as ACEs, which I'll explain in the next slide, have likely increased during the pandemic as well. And what we have seen even historically before the pandemic, that about 60% of children have been exposed to violence, crime, or abuse in their homes, schools, or communities. And this takes a large toll on society, on families at large. And it's not just an emotional and physical toll, but it's also a costly toll. It costs about $247 billion a year to address the sequelae that happens from being exposed to violence, from having some kind of trauma in your life. And my study is basically how to intervene on that, but I do want to touch base on the types of ACEs and the ACEs study as background as far as why I'm so interested in this issue and how it really relates to physical health, and why it's linked with obesity, especially among young children. In 1998, Folletti led a study in San Diego at Kaiser Permanente, where he surveyed mostly adults of white middle class backgrounds on their childhood exposures. And in the purple box, these are the 10 childhood exposures that he measured. So he looked at abuse exposure in childhood. So that could be emotional, physical, or sexual. He also looked at neglect, either emotional or physical neglect. And then household challenges. Was there substance misuse in the home? Any parent or caregiver with mental illness? If that person themselves has had suicidal thoughts or behavior, if their parents at a young age were divorced or separated, if they had a parent who had been incarcerated, or if there was intimate partner violence or domestic violence in the home. And what they found in that study in 1998 was that more than half of the participants had at least one ACE, and 1/4 had 2 or more ACEs. And what that meant was that those childhood experiences had an impact on their long time physical health, which I'll go into later. But since that study, there has been multiple other studies looking at other communities, because the first study was predominantly middle class white population in Southern California. And so there was a Philadelphia study, and since then there has been now a national effort to try to record what are the types of adverse childhood experiences that children are actually going through or adults have experienced in the past. And some of the other adversities that have come to light are things like bullying, community violence, and I'm really highlighting community violence because that is definitely an issue that's affecting our communities right now. Natural disasters, and this includes things like the COVID-19 pandemic that is sort of like a natural disaster. Refugee or wartime experiences, witnessing or experiencing acts of terrorism. And I would say racism and other factors are also important to think about and include in these adverse or traumatic experiences that children are faced with. And so when we think of adverse childhood experiences, there's really a connection to adverse community environments. And this figure here kind of shows how the two are related. The roots here are the environment in which folks are living in, right? And so these contribute directly to those adverse childhood experiences: living in poverty, facing discrimination, community disruption, lack of opportunity or economic mobility and social capital, poor housing quality, affordability, violence. These adverse community environments feed, unfortunately, into the adverse childhood experiences that sometimes children are faced with. And ACEs can have a lasting impact on health, including increasing the risk for obesity, diabetes, depression, suicide attempts, STDs, heart disease, cancer, stroke, COPD, and behaviors. So whether or not they're more likely to engage in smoking or substance misuse or addiction. And then life potential. So it affects, unfortunately, graduation rates, academic achievement, their work productivity. And what we've seen through various studies and work is that the risk for negative health outcomes and negative well-being outcomes increases with the number of ACEs that a person has been exposed to. So unfortunately, there's a graded dose response. For example, a person who has 4 or more ACEs, so right here in this bar, has a 4 to 12-fold increase in health risk for alcoholism, drug abuse, depression, and suicide intent. That same person who has 4 or more ACEs, and this is all in comparison to those who have no ACEs, has a 2 to 4-fold increase in smoking, poor self-rated health, physical inactivity, and obesity. So the impact of ACEs is great. It increases the risk for disease, for early death, for poor social outcomes. And unfortunately, it's a cumulative effect that lasts beyond childhood. And ACEs can be passed down from one generation to the next. And unfortunately, there's certain groups that are affected more by ACEs than others. And typically, people of color, unfortunately, are one of those groups that are significantly more affected. And we know that it's because of the environment, it's because of structural racism that contributes to all of this. People who are unemployed or unable to work, people who are making less than $15,000 per year, people with less than a high school education, or who identify as LGBTQ. And so now I just want to give us some perspective of the ACEs proportion in Los Angeles County. And this is a study that has been conducted through Let's Get Healthy California. And this data is ranging from 2016 to 2019. So this is pre-pandemic. And all of this is parent reported data on their own children. So parents in 2016 reported 16.7% of their children had 2 or more ACEs. And this is just a summary of how many ACEs parents reported of their children. As you can see, a little over half reported no ACEs. About 31% reported 1 ACE, and then 16% 2 or more. And what we've seen is that ACEs health impacts start early. Through the Center of Youth Wellness, who the former Surgeon General, Dr. Nadeem Burke-Harris, led, they did a study of 702 patients, ages 0 to 21, with a median age of 8. They found that 2/3 of the children had at least 1 ACE, and 12% had 4 or more ACEs. Of those that had 4 or more ACEs, 32.6 they were 32.6 times more likely to have a learning or behavioral problem. And they were also twice as likely to be overweight or obese. So right now we're starting to see the link between adverse childhood experiences or trauma, otherwise known as also toxic stress, does have an impact on physical health, and it can start early. Well, let's talk a little bit about childhood obesity and where that's at in Los Angeles. Childhood obesity is a growing epidemic in low-income minority communities. In 2019, about 45.6% of fifth graders in Los Angeles County were overweight or obese. And that number has likely increased during the pandemic because of stay-at-home orders and virtual school instruction. And unfortunately, a lot of the interventions that address childhood obesity really doesn't take into account that social emotional trauma, adverse childhood experiences that may have happened in the past and how that has impacted their overall health and well-being. Most of the interventions are targeted on energy balance and individual health behavior change, such as increasing physical activity, working on caloric restriction, which unfortunately hasn't made a long-lasting impact on childhood obesity prevalence. So that brings me to this place of what we really need to work on is integrating trauma-informed care to mitigate the effects of trauma or adverse childhood experiences or toxic stress on physical well-being. And trauma-informed care, and I'll refer, it will be on the slides as TIC, is an approach that incorporates an understanding of the unique consequences of the history of trauma on health and developing a trusting collaborative relationship with providers to help patients address their healthcare needs. And currently there is limited evidence on how a targeted trauma-informed care approach in childhood obesity counseling could affect childhood obesity in under-resourced communities of color. So the purpose of my current work is to examine changes in childhood obesity associated with the implementation of a trauma-informed care approach called Families Overcoming Under Stress, with weight counseling and management among low-income minority children in a primary care setting. Just briefly, a little bit about FOCUS, or Families Overcoming Under Stress. It's an evidence-based trauma-informed social and emotional learning program that is tailored for the school setting. Currently, it's being facilitated by psychiatric social workers within LAUSD, but it also has a component of family-based therapy in clinical settings. It incorporates social emotional learning skills, which really is a framework for building resilience and a way to address trauma. Those skills really hone in on emotional regulation, social awareness, relationship skills, responsible decision-making, and managing stress reminders. And I just wanted to draw a comparison between resilience characteristics and social emotional skills and how they correlate with each other. So resilience really can be divided into two assets, internal assets and external assets. And this is really about the individual. It could be a child, it could be an adult. But in this case, I'm referring mostly to the child. But the internal assets of resilience include emotional regulation, self-efficacy, having goals and aspirations, empathy, cooperation and communication, and problem-solving skills. The external assets of resilience include having a caring adult relationship, having caring peer relationships, having a high expectations that usually comes from an adult, but it could be from a peer, and feeling connected or belonging where they're at. And these competencies, or these characteristics, sorry, the resilience characteristics, are complemented by the social emotional learning skills in focus that really hones in on how to be self-aware, how to manage your own emotions, but also how to manage your goals and aspirations, have some social awareness, how other people's emotions may be impacting yourself, developing relationship skills, and responsible decision making. And so in thinking about resilience and how it relates to the intervention, I developed this conceptual model that shows you how the intervention is going to impact a child and parent well-being and develop resilience, and then later impact their health overall. And so here I have the intervention, which is the trauma-informed childhood obesity intervention. And at the bottom, I have some moderators, and really this is both mostly family characteristics, is not just of the child, but socioeconomic status, age, race, ethnicity, what prior adverse childhood experiences they've been through, what stressors they have in their lives. That could definitely impact how they are resilient, right? And I have a mediator, is the parent-child relationship, which is really what we're going to be trying to work on in this intervention, is really trying to build that parent-child relationship or caregiver-family relationship. And in there may be some already cultural views or personal views of health that would impact how they see themselves, and how this will eventually impact their resilience. And so through the intervention, we're hoping to increase resilience, and we're going to increase resilience through building this caring adult relationship, building high expectations, connectedness, belonging, and these internal assets. But as time goes on, we hope that we'll see the distal outcome of decreasing their BMI, which is a measure of their body weight or obesity, increasing those health behaviors, and really making sure that they have those linkages to mental health care if it hasn't been already made. And a lot of this work is modeled after the trauma-informed healthcare model. This one is taken directly from the UCSF Center to Advance Trauma-Informed Healthcare. And the thought is, when you have a trauma-informed clinic, you are providing a foundation in which you provide the supportive environment that will be strength-based and will welcome families, whatever place they're at, in helping them identify their strengths and how to overcome adversity. And so as part of it, there's education, there's screening, and then the response. And here is where my intervention lives the most, is in the response. And so here's some goals, and I'll try to be quick. My first goal is to develop a consensus of best practices in incorporating trauma-informed care practices into childhood obesity care through a multidisciplinary approach. My second goal is to co-adapt focus for the primary care setting to address both trauma and life stressors and its impact on childhood obesity. My third goal is to examine the feasibility and acceptability of delivering the adaptive focus intervention in the primary care setting as perceived by caregivers or parents of low-income minority obese children and their providers through a mixed methods approach, and then explore whether this intervention decreases BMI, increases linkages to behavioral health services versus usual care, and how that may vary by ACEs exposure. So for the first goal, currently I am working on recruiting community stakeholders and experts in the field to really have a discussion through a series of surveys and focus groups about how to best integrate trauma-informed care practice into childhood obesity care, and specifically for low-income minority communities. And so here I listed some organizations that I plan to target for this panel, but in preparation for it, in the last couple of months, we've been doing a literature review to find what is the current standard. And really, there wasn't much out there, but here we have a general approach in which we use some of the principles, or the 6 guiding principles of trauma-informed care, and integrated it into important aspects for obesity care. I'm not going to go through it all right now. I'm just going to move forward. But that is an ongoing project that I'm doing simultaneously as I'm also developing the intervention with my partners at UCLA, the developers of Focus, the UCLA Nathanson Family Resilience Center. And so far, what we've decided is that this is going to be more of a health educator model, where we're going to have primary care providers refer children, and we've targeted an age of 5 to 11-year-olds who are obese or overweight and have a BMI of 85% or more, and their caregivers with any ACE score. And our plan is to have them attend sessions, about 8 sessions over a 2 to 3 month period that will give them all of those resilient skills, work on building that parent or caregiver-child relationship to build their resilience and also address their health care needs. As we're doing this, I'm also in the process of recruiting CDU faculty, I'll send emails soon, and members of the local community clinics that I'm working with to provide to get their input on the intervention development and how feasible it is. As far as system level implementation, I have at least 3 primary care partners that I've been working with. Thus far, all providers have been trained to conduct ACEs screening, and currently we're developing methods of sustainability as we're talking about implementation, really thinking about how to create this pilot project into something that will be long lasting. And so medical billing is one of those issues. Also developing and refining a clinic workflow. And so overall, the timeline for the intervention portion of the study is going to be over a course of a year. In the recruitment phase, we plan to do a pre-survey, and we're going to be doing child and caregiver measures, and we're also going to do electronic health record data extraction, where we'll be getting information about their ACEs score, their BMI, any referrals that have been made, but we'll also be surveying both the child and the parent on their resilience level, on how they see themselves as far as their physical health, and how they see themselves as far as measures that are related to emotional eating. And we plan to report back those results within the intervention as they're meeting with their health educator, and then have the same measures be measured again in the post-survey, and those results be reported back to, and at every follow-up. And so I just mentioned briefly some of the surveys that we have in mind for the intervention. So we will have a child survey, a parent survey, and we'll also conduct focus groups with providers and parents to assess the feasibility and acceptability and satisfaction of the intervention. And we also plan to do medical record data extraction. And overall, our expected results will hopefully impact overall resilience in both the child and the parent. And in the child, we're hoping to see a decrease in BMI, but also increase of self-reported health behaviors and linkages to mental health care. Okay, so I want to thank everyone that has supported this research. So everything that I presented here was supported by NIH, NIMHD under the CDU Access Center grant and the UHI Emerging Scientist Award, and also the UCLA, UCSF, UCAN grant. I also want to thank UCLA Nathanson Family Resilience Center and the CDU HRSA grant team.
Thank you so much, Dr. Venegas-Murillo. Great presentation. Do we have any questions?
Yes, I am trying to see if I can. Can you guys see me? Or can you, Angela, can you hear me?
Yeah.
Well, first of all, Dr. Venegas, I want to thank you. This is a very important and critical study, and I wish you all the best. Looking forward to see your data because I think there is a tremendous need for this. There are two, I think you probably have seen this. There's a paper that was published in JAMA, and I think it's in 2021, where they clearly show that there has been almost the adult obesity incidence rate has quintupled between 1976 and 2018. And in that paper, they actually talk about what possible factors, contributing factors are, as well as impacts. And one of the areas, of course, there's some concern about increasing obesity at a young age, and the cohort that they looked at was between 18 to 25, and the risk for developing cancer down the road. So I'd be very curious as you begin to bring your cohort into study, maybe we can help you and collaborate to begin to find out risk factors. I would also be very curious if you can, and you've shown in your pictures in the tree about maybe some of the factors which will be obviously be impacting. But I think it'd be good to see what specific social determinants of health are being impacted, in particular our catchment area. So this is something I think if you can connect that, that would be great. The other comment I wanted to make, and you may have seen this, and many of you may have seen this, CTSI just released a announcement. So this is a work that CTSI is doing in partnership with Lundquist and Harvard UCLA. I noticed you've got some collaboration with Lundquist, and they are working together to build a hospital-based violence and intervention program and a trauma recovery center focused on community engagement research program. Given that many of our faculty, as well as our community partners, have been actively involved with the community engaged research program, I think it would be a good idea to see how we can partner, or you can partner with this particular initiative.
Definitely.
And I'm happy to send you that information.
Yeah, thank you, Dr. Vagama. I mean, first of all, I already signed up for that meeting, the talk with, with the hospital-based intervention. And so, yes, I'm happy to help and collaborate and in any way possible with that team and also with your work. Obviously, the impact on health extends beyond childhood obesity, right? Yes. But this is a start. It's a way to address one issue that may be disseminated to other aspects of health. And so the whole idea here is prevention and starting early. You know, with my community partners, they want to start as early as birth, and I want to too. But I think right now, we're just trying to see that this works and that we're able to prove that families are interested and want this before we start disseminating largely.
Good, good. So looking forward to your outcomes and good luck again. And I see a lot of our community faculty are on the call. Highly encourage you to engage in this initiative with Lundquist and UCLA CTSI. Thank you.
So it looks like Dr. Denise Shervington has a question. Dr. Shervington, would you like to unmute yourself?
I did, thank you. Dr. Venegas, thank you for your presentation. I want to bring up an important finding of the ACE study that I find a lot of times get ignored, that there was a fourfold increase in obesity in women who had histories of sexual abuse. I find that in many of these spaces, this is something we try to stay away from, and I think it will need to be addressed. And, you know, as you do the work. The other thing I want to comment on, looking at some critiques to certain SEL curricula, there's an assumption that young people in these SEL classrooms or wherever it's going to be done have healthy attachment, because the SEL really depends on those early years of attachment, and many of the children who've been found to not do so well, if you go back and take a careful history, they've experienced the first relational trauma, which is attachment trauma. So again, I'm wondering how, as you're in that intervention, you're going to have some assessment of the quality, the early nature of the attunement and attachment of children with their primary caregivers, because that is really going to predict the extent to which 8 lessons on SEL is going to have an impact.
Definitely. We are measuring the family functioning through the family assessment device. And I welcome any other suggestions of any other measures that would be helpful to kind of measure that or help assist in that. And our goal is to report back, right? So like when we do a measure, we do it with intention and meaning that it's going to help families build that relationship. So we're going to give that information right back to them.
Thank you.
Will there be some awareness on the part of the educators that there's a very sensitive potential issue of sexual abuse and how to manage this?
Yes.
What happens if a child reports that they're having these experiences?
Right. So we have a clinical psychologist on our team who will be essentially on call for those acute, stress situations where you need immediate attention. We will also rely on the healthcare services that are already established. This is all happening through the primary care clinic, and the ACEs screening is done by the provider. So it may have been revealed there, it may not have been, right? And so I agree that we do have to be prepared and aware that it may come up in one of these meetings.
Thank you. In the interest of time, I'd like to move on to our next speaker. And if you do have questions, you can either type them in the chat and Dr. Venegas-Murillo can address them there, or you can also email her as well. Next, I'd like to give Dr. Dilara Üsküp to present her research. Dr. Üsküp, you have the screen.
Yes.
Okay,
thank you. And thank you so much, Dr. Venegas. I have some questions for you also, and I hope to be able to connect with you. All right. And I just have to alert everyone that I'm working off of 2 screens. So if you all see me looking at the other screen, please be advised I'm working off 2 screens. All right. So this project is from preliminary 2 screens and a mouse. This project is from preliminary results from my study exploring the use of cannabis and pain management for pain management among Black Americans here in Los Angeles. And it was supported by the National Institute of Neurological Disorders and Stroke, as well as the Urban Health Institute. And the views that are expressed here do not represent the official views of the NIH. All right, so if you read the news, you see that cannabis affects all systems of the body, or so the different articles that you may see get you to believe. So anxiety, appetite, feeding, blood pressure, bone formation, cerebral blood flow, digestive system, enemas, emesis and nausea, immune system, inflammation, impulsivity, all these systems, pain, reproduction, stress. And now I'm even seeing, that cannabis and cannabinoids might also impact COVID and COVID-19 symptoms. And so while there is a lot of you can pretty much look in reports and look in research data, and you can kind of find what you want to find in cannabis. My focus here today is going to be cannabis as it relates to impulsivity. The larger focus is on how is cannabis functioning as a neuroprotective and neuroprotection, and then also this piece on cannabis and pain. So what we know is that Black Americans experience racial disparities in pain assessment and treatment recommendations in the clinical setting. And they're more likely to use over-the-counter solutions and non-prescription medications and salves and creams to treat their pain. And then they also use alternative methods of pain control. And there is a reluctance on the part of some physicians to prescribe opioid medications to opioid pain medications to Black Americans. But there's also an aversion that Black Americans have to, because of medical mistrust, to big pharma and healthcare systems and what they feel is pharmaceutical medication. Now, whether that is over the counter or whether it's prescription grade or not, there is that same kind of aversion and apprehension to using a pill, so to speak, and using medication. So with that, I'm curious about how Black Americans may use cannabis as a preventative or adjunctive measure to their to deal with the chronic pain that they may be experiencing. And what we know is that while cannabinoids and cannabis, can improve some aspects of chronic pain, cannabis can also cause some adverse health outcomes. So I'm not going to get into all the potential adverse health outcomes, and a lot of this research is still developing, is hotly contested. But we do know in some cases cannabis can impair cognitive and psychomotor function, and it can interfere with complex executive function tasks, including the ability to plan, organize, solve problems, make short-term decisions, learn, retrieve information, regulate information, and behavior. I'm also kind of thinking about this question around sex and biological sex. So what's sex got to do with it? And we also know that there are sex-specific differences between males and females who are cannabis users. So within cannabis smokers, men exhibit greater cannabis-induced analgesia and more pain relief relative to women. And there are sex-dependent differences in cannabis's analgesic effects, and that's important. But there isn't a lot of work that's looking at Black populations specifically. I'm not making a case that Black folks genetically are different, but I'm curious to see what their experiences are in this space. And most of the research is among Black Americans is among men. So very much concerned with this issue of sex, this issue of cannabis use, and then the setting of chronic pain. So given cannabis's ability to reduce pain ratings, does cannabis use among Black women and men with chronic pain linked with poor executive function scores? And then does it actually reduce ratings in pain? So here are my specific aims, and in the interest of time, I have more slides than I have time, so I'm just going to kind of click through some of this and just kind of get to the meat of the presentation. And so my research strategy was mixed methods, and I've been in the field this past year doing this mixed method survey where individuals who are 18 to 60 are using cannabis for their chronic pain management and who are Black American in the Los Angeles metropolitan area take part in the study. And what they're asked to do is submit the result of a urine test, a urine THC test. They're also asked to take an online survey, and then we do a semi-structured interview with them. And then in addition to that, I do also have the BART task, which they took, which is the balloon analog. The BART task is a balloon game that folks play to determine how risk averse folks are. Or how risky they are, and they pump a balloon and they're kind of rewarded. They're not rewarded actual money, but they're rewarded hypothetically 25 cents a pump, and then it continues to increase until that balloon pops. So that was how I assessed risk. That's how I assessed risky behavior. And the greater the risk, the greater the reward. All right, so today I'm focusing more so on my preliminary qualitative insights with 26 participants. And so the 3 insights I want to kind of pull out are thinking about the unique experiences of Black Americans, the analgesic effects, as well as the mode of administration. So here are some of the themes I want to pull, and that's consuming cannabis while Black, and the experience that Black folks have with the medical system while using cannabis, and maybe why they use cannabis, the pain relief, the analgesic effects, and then also the modalities are, and what I'm going to point to is Black Americans smoking blunts, and then also this kind of phenomena of them trying to titrate and moderate how exactly they're using cannabis. All right, here you see a mix of respondent ages. So I have some demographics. We have the income represented here on this graph. We have work arrangement, and most folks were either working full-time or part-time, and we also had students. A very limited number of folks were on disability. And I also had this question about last visit to the doctor, just to get a sense of, are folks engaging with the healthcare system? And if so, when is the last time that they engaged with the doctor? All right, the first effect is the analgesic effect. And here I have a 38-year-old Black woman. And what she talks about here is that cannabis helps her zero in on the pain, and that when she's able to know exactly where it's hurting, where she's having pain, she's able to use other over-the-counter treatments like an icy hot, and she knows exactly where to apply. So she's using cannabis to kind of sensitize her, and then use another non-pharmaceutical, non-prescription method to support her pain relief. This Black male says that, you know, he talks about his pain, and then he says, I actually feel a lot better, or my knees feel a lot better. And he's talking about the pain that he has in his knees when I'm high. And he just says that he feels less pain. And through that realization, you know, he's able to feel less pain, and he knows that cannabis gave him that realization, and he knows that cannabis can help him relieve some of that. Here with administration, highlights the mode of administration. What I really want to highlight is that folks are very much concerned about healthiness, how they're using cannabis. Is it a healthy modality? The way in which that they're consuming, is it not, et cetera. So this respondent was, woman was talking about going to a little a pipe, and perceiving that the using a pipe was healthier than using a cannabis joint, or using a cannabis blunt. So there's this kind of focus on how can I be harm reductive in my, or at least harm reductive, or at least there's some awareness that there could be some other adverse side effects of using cannabis. Here, this participant, this Black woman, was talking about the same kind of piece around healthiness. So she talks about using pipes. Sometimes she's consuming cannabis, you know, edibles. And then she was talking a little bit about rolling blunts, and talking about rolling the blunt in the Dutch leaf. And she talks about this kind of concern about this concern of the effects of tobacco and cannabis co-use on her lungs. And then she highlights that, hey, COVID happened, and she became even more concerned about the type of cannabis, the modality of cannabis that she was using, and potentially, you know, thinking about, you know, how she could go to another modality that could be less harmful than using the Dutch tobacco leaf. Here, this user talks about using cannabis 3 to 4 times a day, but in the end is trying to space out how cannabis is being used, and also that, you know, that they're trying to stretch that cannabis consumption out. So there's this overwhelming thought that folks are just kind of staying high, you know, consuming cannabis multiple times every hour, and that's really what I'm not really seeing that. I'm seeing that either there's a clear pattern that people have established, you know, a morning, afternoon, evening, or that pattern of use is based on pain, or that pattern of use is based on what tasks the person is completing. So this person uses it 7 times, and that doesn't mean that they're necessarily consuming a full joint, or a full blunt, or a full edible, but they are kind of dosing that throughout the day, depending on the tasks that they are taking care of. And these are just some more kind of highlights around how folks are titrating cannabis. So I'm going to just kind of move through here quickly. I also want to say, some folks asked me before as I was in the field, like, why are you studying Black people? I'm a non-Black person. I had some non-Black folks trying to be a part of the study. And one thing I like to stress is that there are, and I think our last speaker did a great job in talking about adverse childhood experiences, but there are certain unique racial experiences that Black persons, as far as stress, as far as trauma, as far as how they experience the world with discrimination, that they experience that non-Black folks don't. And so this one woman in the study is talking a little bit about having a young son, the death of George Floyd, her son's name being Floyd, him being worried about being killed because he's Black, and then also how she doesn't do it all in this one sentence, in this one paragraph, but she talks a great deal about how that additional stress of being Black and COVID and the death of George Floyd really impacted her use of cannabis. So there are these other experiences and stressors that Black folks are having. Same thing when Black folks are going into the dispensary setting. If they go into one dispensary that may be in their community of Black or brown folks, they have one experience, but if they go out into different communities, they may feel criminalized. And security might be passing judgment or walking around or not really taking care of that, walking around that individual and not taking care of that person in the same way the bud tenders as they are of other individuals. So there are these also racialized, impacts that are happening to folks when they are in the setting of just even trying to procure cannabis. So here, just really quickly, what in the medical insights, I do talk a little bit about what happens with folks when they go they go to the doctor. And what I see is a recurring theme of mistrust of big pharma, mistrust of doctors, and kind of the thought is, hey, this doctor, she's on the side of pharma, he's on the side of pharma, they want me to take the pharmaceutical medications. They're not really as open to me taking cannabis. So there's this kind of apprehension. And we see this kind of theme here, where the patient isn't really asking, or the patient isn't going to the physician asking for permission, about cannabis, but they're kind of asking for information. So some patients are experiencing asking information. In other cases, respondents talked about using cannabis because they had other obstacles accessing prescription pharmaceutical drugs, or that they had issues accessing a doctor. In some cases, folks in the study who had chronic pain self-diagnosed, and then they began using cannabis to manage that pain. So we see this piece around healthcare access is also very important in cannabis usage. So I'm still analyzing data. I'm very much interested in this concurrent role of tobacco and nicotine in cannabis usage. I did submit a TRDRP grant, and I'll be resubmitting that grant this year. I'm working on a qualitative paper that I'm going to be presenting a poster on at the College on Problems of Drug Dependence. And then I'm also working on a larger study called CaliCan, a demographic analysis of the state of California cannabis marketplace. And that's work studying both consumer behavior and also studying cannabis owner operators. I'm also interested in this question about COVID-19's effects on cannabis use, and if there are any opportunities for collaboration, I certainly welcome them. And I just want to thank everyone and thank the Urban Health Institute for allowing me to present here today. And I just included my contact information should anyone want to reach me or my team directly. Thank you.
Thank you so much, Dr. Üsküp, for an excellent presentation. Are there any questions?
No, I just want to comment. Dr. Üsküp, it's finally great to see you. You and I have been interacting via email, so I'm glad I get to connect with you, at least via Zoom. Hopefully, I look forward to see you in person very soon. Great project, very important, and looking forward to help you in any way we can.
Thank you so much, Dr. Vergama.
Sure.
Thank you, Dr. Vergama.
Hi, Dilara. It's Dr. Abraham from Kedron. How are you doing? Great presentation, and Angela as well. Great to see you both. Wonderful lunchtime talk. A couple of quick questions. Definitely curious about how and the form people are consuming it. So you mentioned a little bit about edibles versus pipes or blunts, or just curious how that affects. And then, objectively versus subjectively trying to quantify dosage is very interesting. So would be curious to hear more if you're able to go back to any of these individuals and try to see if they can subjectively quantify, and then how can we try to create some sort of objective measure for that. Did anybody report any side effects, harms, or adverse events from their use? Now, we used a couple of words, cannabidiols versus cannabinoids versus was it cannabidiol? So there's like a few terms, right?
THC. Mhm,
Right,
mhm,
THC. So did they endorse any sort of, anybody have any issues with increased anxiety or panic or psychosis or cyclical vomiting syndrome based on a certain dose? Were any of those kind of things endorsed?
Yes, so thank you so much for all your questions. I'm going to start with your last question first. I didn't hear anyone talk about cyclical vomiting, although folks did have some adverse events. They wouldn't say side effects. So when I asked them a question about side effects, they would say, oh, no, I don't have any side effects. And I would say, okay, well, did anything happen that you didn't like? And then they would talk about grogginess. They would talk about sometimes anxiety. In other circumstances, they would talk about, the fact that they would sleep too long, so they enjoyed the sleep, the ability to be able to sleep more soundly. But then, in some cases, that sleep was a little bit more extended. Also, queasiness. So they may not have vomited per se, but they did experience this. But this what I want to pull out there was to the point of folks don't want to talk about side effects, but they're happy to talk about and then I'll say, oh, it doesn't have to be bad per se. It's just did something happen to you that you didn't like, and then they would talk about that. In terms of the modalities of use, primarily with smoking, I can say that the majority of people, maybe except 2 people in the study, all experienced consuming blunts at least one time in their life, and most of I would say it was a good 30 to 40%, and I haven't pulled down all the, I'm still going through the data analysis, but a good majority were either still consuming, largest majority were consuming joints, and then they were also using these blunts. And even if folks, like one person, she's no longer using blunts, but she did use it one time in her life. So I thought that was very striking and very much consistent with the literature. What was the other question? You had one other, I think, like maybe 2 other questions that I.
Just the way they consume it, and then trying
the
to
timing. Yes.
objectively quantify dosing.
Right. So I do have different measures in the survey that ask about, and like, standard measures, quantifying it. Do people eat it? Do people smoke it? And then, I do try to ask in the interview, how many, like in a joint, like how are they taking 1 puff? Are they taking 2 puffs? So I do try to get at that qualitatively. Unfortunately, and this is what I know on the side of working with LADC, the Department of Cannabis Regulation in the city, that it is so hard to kind of quantify the amount of cannabis. Well, it's hard to quantify the amount of THC in cannabis, one. And then I also had participants, and I didn't talk about this, who were using both cannabis that was from legal dispensaries or retailers. And then I also had folks who were using cannabis, and they knew that it was not from a quote legal dispensary or retail location, and they were doing that because that cannabis was cheaper. Well, the likelihood that that cannabis is tested is completely unlikely. So, you point out great. It's a great question, and it's also a critique of how we're doing cannabis-related science right now, because it's really hard to be able to quantify. And I know some folks in Washington, and they have like a van, and it pulls up, and then people get on the van, and then they consume their cannabis, and they're able to do some extensive testing. But between folks getting both licensed product and unlicensed products, and then the different concentrations of THC, and then also each person's body composition, that's still more subjective and a little less objective. So I do have to confess that limitation.
Thank you so much.
Thank you very much, Dr. Abraham, for your question. It looks like Donisha Beaver, you have a question? You're on mute.
Hi, good afternoon. Thank you both all so much for your presentation. Good to see you again, Dr. Dilara, and hear the work that you're doing. I also had a question with regards to the type of cannabis that is being consumed, particularly around the strand of the cannabis that the participants are using within your study? Are they more connected to the more popular brands that are in culture, the more medicinal brands that one can be prescribed if they're dealing with pain management issues? And so is that a part of the study to assess the strands as well as the branding of the cannabis usage to see what's happening in Black American usage, as well as the if anybody is experiencing socioeconomic challenges or issues, the impact of costs, because we do know that cannabis can be costly as well, depending on the type of cannabis that's being purchased and the brand of that cannabis that's being purchased.
Yes, Reverend Donisha, thank you so much. And just really quickly, we know that cannabis can be cost prohibitive, and that's why folks were using unlicensed dispensaries or unlicensed cannabis retailers to access more cannabis to manage their pain. And there are a mix of programs for folks to be able to access cannabis at more affordable prices, one being a program through the county, but I found, and you can get a county, it's called a marijuana identification card, and that gives you some tax relief, but most folks did not know about that program, number one. And then your question about the type of cannabis. So we know that there's one genus of cannabis, and that's Cannabis sativa. But if you talk to any person, they're going to make an argument about hybrid, indica, sativa. And so there is also these views about the hybrid indica sativa debate. And folks really do feel that one or the other or the third type impacts their body. So it would largely depend, but there was also this subjective understanding of these quote unquote cannabis types, even though we know pharmacologically there's only one cannabis type. As far as the advertising, I didn't really delve too much into that, but I'm very concerned about where cannabis is going, both with how it advertises to women, pregnant women, and people who are pregnant and nursing and breastfeeding, and then also also to children, and also how it's advertised within the Black community. So I haven't gotten there yet, but it is an area of concern, and most importantly, I'm concerned with legalization, that the same thing that happened with tobacco, we're going to see the same thing happen with cannabis. So I am very much concerned, but my research hasn't touched on that yet.
Got it. Thank you. I was looking more to see if culture was influencing their usage. So when we think about Nipsey Hussle and Marathon Kush or LA Confidential and some of the other brands that are out, is that influencing the type of marijuana that they're using based on age and culture and context?
Right. So if anything, culturally, I just say quickly, I think the biggest influence is just the blunt consumption. And I didn't really see folks were more likely to name a Swisher or a Backwood, the type of tobacco wrapper that they're using, but not so much brand of cannabis. And I think most folks are just trying to get the most bang for their buck, so to speak, so that they can, really, use it. So I didn't see as much of the association with, these celebrities and their branding. I think most folks are trying to stay away from some of those brands because they could be a little bit more cost prohibitive, but they're more so concerned with gaining more purchase, and then that modality so Nipsey Hussle or Snoop Dogg using a blunt, that would be a little bit more culturally influential, or Backwoods, or for instance, and then that brand being propped up within the community.
Got it. Thank you.
Thank you. It is now 1:04 p.m. and we are over time, but I don't want to rush anyone off the Zoom. I welcome any discourse for Dr. Üsküp or Dr. Venegas-Murillo. I know there are quite a number of comments and questions in the chat. I've taken a picture of them and I'm going to be sure to send it to each presenter. So what would you all like to do? Would you like to continue?
I just want to thank you, Caroline, and I want to thank the speakers and everybody who is joining. Thank you so much, guys.
You're welcome. Thank you, Dr. Ragama, for joining us, and thank you for your leadership.
Sure, anytime. Take care now.
Bye.
Bye-bye.
Take care. Okay, so
I did have one quick question I wanted to squeeze in to Dr. Venegas, if that's okay. So and this is not from a research perspective, but from a community perspective, working in violence prevention in Chicago that I had some years ago. And so I just love what you're doing in this space of ACEs. I'm wondering, because you talked a little bit about a multidisciplinary approach. So I'm wondering the role that you think food and nutrition, food access, food security, food insecurity, would play into this intervention. Because folks who are low income may be accessing SNAP benefits, and we know that sometimes it's a matter of there not being a grocery store that sells fresh fruits and vegetables, but then in other cases, folks are making decisions to really extend those SNAP benefits, and packaged goods, canned goods tend to be less cost prohibitive, and then also have a longer shelf life. So I'm wondering, in addition to thinking about the ACEs and particularly violence and gun violence, how do you prepare parents or better resource parents with nutrition education, and then also, thinking about some of these pieces I'm raising around the SNAP benefits?
Yeah, I think honestly, the way we're looking at this intervention, it's going to be really tailored to what the families highlight as a need and what's important to them. And it may be that particular issue is not the center of why they may be faced with eating more chips, or you know what I mean, or making those decisions of buying fast food, and so if it were like, we're going to be prepared for all of those aspects. So if we do have community partners that we are working with within Harbor UCLA, they have contacts with some community resources that can provide more guidance as far as how to access healthy produce within your community. But if that is not the major issue that folks are bringing up, we're not going to stress on it, and we're really going to focus in on what the family needs. And so in our first session, that is the goal, is to address what their goals are. How do they see their own health? What do they see they can do? And so we're going to try to work with families on that individual level in a way, to address their needs, rather than doing this prescriptive approach where we're going to say, like, this should work for you, right?
Thank you. It looks like Dr. Chavez is still on, and he had a question for you, Dr. Venegas. First he says, great presentation, and Angela, your work on including TIC is even more critical now. Any thoughts about parent-child dyads dynamics based on gender of parent and gender of child?
Oh, yes. So I briefly answered his question about that, but historically, there has been studies showing that women in the household tend to be the decision makers as far as what foods are bought, about the health of the household. And so that is definitely a challenge that we're aware of. Unfortunately, we're not targeting one gender in this study. We're going to focus in on whoever that lead caregiver is for the child and try to work from that angle. But I do feel that men, unfortunately, haven't historically been present for a lot of healthcare visits with their children. It's usually a female person or caregiver role. That is usually the most predominant figure. And I think those are things that we need to work on as a society, to kind of break those barriers.
Okay. Thank you. And the last question is for Dr. Üsküp. It's also from Dr. Chavez. He also says, great presentation and very interesting topic. I'm wondering about how research views the role of cannabis as a barrier for perhaps facilitator in accessing other types of healthcare or behavioral approaches that are helpful, such as dependency on cannabis that may both be helpful or pain, physical or emotional, like other medicines, more short-term, but longer term impact that may be harmful?
I think the larger barrier here is not so much cannabis, but really medical mistrust and the racial, the kind of racialized experiences that Black folks have with the medical system. So, cannabis in some ways, the pain that a person may have, may encourage them to, connect with a provider. But if a person doesn't have access to healthcare, if a person is mistrustful of the healthcare system, if they've had negative experiences with other physicians, then there is a larger likelihood that they're not going to be enthusiastic about engaging with the healthcare system. And not only that, but talking with someone in the healthcare system who they don't trust about using what is federally considered an illicit substance. So, cannabis is still a Schedule I drug, and on the side of the medical institutions, I don't think our medical institutions do a very good job at training physicians and training physicians on cannabinoids, and there's an addiction science perspective, but there's not so much of a perspective on cannabis as a therapy on the therapeutic benefit side. So there needs to be more education of trainees, but also on doctors, and then also I still think you're going to have a little bit of apprehension because folks may not want to suggest in the healthcare setting that they're using a substance that's viewed as illicit by the federal government. But there are opportunities, through more education, through more through us kind of going out into the community as researchers, as physicians, and really having these conversations with folks. But I would say that the larger story is about the medical mistrust, but cannabis does also play into that. Thank you.
Thank you very much, and thank you everyone for attending. I hope you have an enjoyable rest of your day. Take care.